So what are the standard first and second line treatments for patients with metastatic gastrointestinal stromal tumor?
So the standard of care is imatinib in the frontline setting. Imatinib has set the bar quite high. The two large randomized studies conducted on both sides of the pond and the analysis put together called the Metagist analysis has clearly given us a indication that the median overall survivals that used to be in the 1 to 1.5 year range in the pre-TKI era on imatinib have certainly gotten closer to almost close to 5 years. And there is pretty long-term data with follow-ups approaching 10 years to support this. The unfortunate reality is that unlike chronic myelogenous leukemia and imatinib, the tails to the curve seem to be drifting down. The slope is downwards. We don't see a flattening of the curve. The B2222, the registrational trial with the longest follow-up, kind of gives us some hints that about 10% of patients with metastatic GIST will still have controlled metastatic disease at 10 years with imatinib, implying that development of secondary resistance is fairly universal. The median time to development of secondary resistance, AKA median duration of response to imatinib in the frontline setting, happens to be close to 2 years, give or take a few months here or there. Once patients have failed imatinib, or I should say imatinib has failed the patient, the approved second line agent is sunitinib that was tested in that setting, randomized to placebo. And the median progression-free survival with sunitinib in the second line setting appears to be approximately 6 months. That got the drug approved as the standard of care second line therapy. Unfortunately, again, yet resistance development is fairly common. And the approved third line agent is regorafenib that was approved based on the GRID trial. Again, randomized to regorafenib versus placebo. And the median progression-free survival for the regorafenib arm is, again, it's a matter of diminishing returns, I guess, as you see PFS in the rego arm going down to 4.8 months. So these are the three standard approved agents or that were approved up until recently. We have a couple of new approvals that I think I'm leaving out for a reason. We can get back to them now or at a later point in time. But for a long time, we had these three drugs, and then we kept looking for clinical trials with newer agents or re-challenging these patients with sister analogs of some of the same drugs. So I just summarized the agents and their efficacy, I guess. Maybe, Andy, you can educate all of us with some more granular details as to their mechanisms of action, what exactly does each one of these drugs do, and why they do what they do.
Sure. So imatinib and sunitinib and regorafenib are all tyrosine kinase inhibitors. Imatinib has what we would consider a pretty clean profile for inhibiting a relatively small number of kinases, which include KIT, among a few others. This probably is why imatinib is generally pretty well tolerated, because it doesn't have a lot of effects on other kinases. Sunitinib and regorafenib, though, differ because they have much broader kinase activity and really are broader spectrum multi-targeted kinase inhibitors. And notably, in addition to KIT, they both inhibit the vascular endothelial growth factor receptor. And that causes probably the biggest share of the toxicity that those drugs can contribute, and that differs from the toxicity of imatinib. And those toxicities can include palmar-plantar erythrodysesthesias, or hand-foot syndrome, hypertension, proteinuria, and some oral dysesthesias, all probably related to the VEGF receptor inhibitory activity. They also probably are more potent KIT inhibitors than imatinib is, and that one way of seeing that is that they are more likely to cause whitening of the hair than imatinib is. They, in addition to inhibiting the primary mutations that we described before in KIT, they also have broader activity across the resistance mutations that present after imatinib stops working. And typically those mutations are occurring in either the ATP binding domain of KIT, which is encoded by exons 13 and 14, or in the activation loop of KIT, which is encoded by exon 17 and 18. And sunitinib seems to have more activity against exons 13 and 14 mutations, in addition to the exon 9 or exon 11 mutations that are the driver mutations, and regorafenib against the exon 17, 18 mutations. So each of them can cover perhaps different areas of resistance to imatinib. So that's primarily how sunitinib and regorafenib differ from each other. They are similar in their KIT inhibitory activity and their VEGF receptor inhibitory activity, but they do have a slightly different spectrum of activity against different KIT resistance mutations. They have not been formally studied in the first line setting. And I want to be clear about that, is that there really is no good evidence for their use compared to imatinib for typical KIT mutant tumors. The efficacy of imatinib, as Shreyesh, as you described earlier, is quite good, as is the tolerance of imatinib. And imatinib still remains the standard for those KIT mutant tumors. It's a little bit more difficult for the SDH deficient tumors, which, as you mentioned, do not seem to respond to imatinib. And because the accumulation of succinate may drive production of vascular endothelial growth factor, there have been some reports of activity of the VEGF receptor antagonists, sunitinib and regorafenib, as well as some other drugs, in controlling the SDH deficient GIST. And that could be a situation where they are used in an earlier line of therapy than imatinib. But other than that, they really are reserved for patients who either progressed on imatinib or who were intolerant of imatinib and could not maintain treatment on imatinib because of toxicity.